Hi, I'm Caitlin from Shadow Health, and I will be giving you a little bit of report here on our patient, Abigail Harris. So, Abigail Harris is an 86-year-old African American woman who came into the ER today with weakness and fatigue. She seems to have worsening depression, but there are several symptoms that overlap with her hypothyroidism. A little bit of background. Mrs. Harris has a history of diabetes, hypothyroidism, and depression, with recent history of nearly falling due to dizziness and unsteadiness. Her symptoms have been getting worse this past week, and she has been taking her daytime insulin, though she doesn't feel like eating. She has very poor energy and appetite, and she lives with her son Terry along with his wife and children, and she feels they're a very good support system for her. She has lost 9 pounds over the past month, and she has been having some trouble falling asleep and staying asleep. She states that she has daytime fatigue, which is worse in the morning and feels like a hangover. Upon assessment, Mrs. Harris is alert and orientated ×4, has a regular heart rate, clear breath sounds, and her head exam is unremarkable except for the dry mucous membranes and lips. Her blood glucose levels are 66. Her urine is concentrated. She took her morning thyroid medicine and her insulin, but reports having little to no PO intake. She has not taken any other morning PO medications. Her depression screen is remarkable for moderate depression symptoms, and her PHQ-9 score is 16, positive for energy, sleep, appetite, concentration, interest, and slowed down problems. She rates impairment as moderate. She displays passive suicidal ideation, mentioning that she would be fine with not waking up at all in the morning. She is a high fall risk, and she is continent of bladder and bowel. Her blood chemistry and urinalysis are consistent with mild dehydration. Some of the medications that she's taking is insulin aspirate, 16 units subcutaneously, 3 times a day at mealtimes. She's taking insulin glargine, 45 units subcutaneously daily. She's taking levothyroxine, 50 micrograms by mouth daily. She is also taking an extended release Effixor XR at 100 milligrams PO daily. And finally, she is taking zolpidem, which is known as Ambien, 5 milligrams PO as needed at bedtime. I recommend, based on my assessment, the depression symptoms are contributing to her difficulty in managing her other medical conditions. She is at a moderate risk for further complications of those conditions. Specifically, I recommend that her diabetes and fluid balance need to be stabilized due to her signs of dehydration and low blood glucose levels. I think we should continue monitoring her blood glucose and PO intake and hold insulin if intake is not adequate. We should correct her fluid balance and ambulate with assistance due to her high fall risk. Toilet in advance of need every 2 hours. And we should screen for her fall risk continuously. We need to educate the patient and the family about her intake and insulin, and assess her sleep quality and quantity. I think we should consult with a physician for a sliding scale for insulin, and we need to consult with a physician about the medication that may be appropriate for the dose reduction and discontinuation, such as Ambien, due to her sleep problems. Some interventions that I performed throughout my time with her. I asked her many questions about her current complaints, history of present illness, home medications, past medical history, social history, allergies, and each muscle group. I performed a depression screen, and I performed a full body assessment and mental status exam. And throughout the entire exam and assessment, I ensured to provide empathy and education on her depression.